So welcome. Thank you so much for joining us. My name is Jessica Shortall. I'm the Strategic Partnerships Lead at the R Street Institute on our Healthier Communities team. And super excited to be joined by my co-host, Gaby from National Harm Reduction Coalition. We'll let you introduce yourself. Gaby Zabala Alemán. She's the Tobacco Harm Reduction Education and Engagement, that's three acronym, project manager at NHRC. So quick intro. We're here today to talk about the intersection of drug use and smoking tobacco, and to hear from practitioners and people with lived experience who are bringing tobacco harm reduction into their work with people who use drugs. We're going to hear real stories. We're going to hear real barriers and challenges, of which there are a lot, practical strategies, successes of trying to integrate kind of cross the streams of harm reduction in a world where they have been siloed off for too long, especially because in this community that we're talking about, people who use drugs, the coincidence of these substances is super high. So again, a quick introduction to our panelists, and y'all jump in if I miss anything about you, please add it. But we've got Kevin Garcia, substance use specialist at the Points West Syringe Services Program. That's part of the Jefferson County Health Department in Lakewood, Colorado. Cyndee Clay, the executive director of HIPS, an organization in Washington, D.C. that provides harm reduction-based services and promotes the health, rights, and dignity of individuals and communities impacted by sexual exchange and/or drug use. And Annie Claycamp, an assistant professor at the University of Maryland School of Medicine and director of research and evaluation at the Maryland Addiction Consultation Service. Annie's joining us as she wraps up a study in which she offered e-cigarettes to older adults attending an OTP, a methadone clinic in Baltimore. So super excited to hear from all of you about the joys and challenges of trying to join these two forms of harm reduction in real life. But before we jump in, I'm just going to note that our panelists may share their own lived experiences. And as always, we ask that people honor those lived experiences, keep the dialogue respectful. You can always jump into the Q&A with questions that we will try to get to. We got a lot of content to cover. So with that, I'm going to pass the mic over to Gaby to kick us off.
Thank you, Jessica. I am very honored to be here in such good company. Again, my name is Gaby Zabala Alemán. I'm the project manager for the Tobacco Harm Reduction Education and Engagement Project at National Harm Reduction Coalition. I am also a person with lived and living experience with tobacco use, substance use, mental health issues, and some other intersections. I am located in San Juan, Puerto Rico, and I am very happy to be joining all of you. Welcome to our panelists, and let's just kick it off with the first question. Which each one of you share how you came to think about tobacco harm reduction for yourselves or within the communities that you serve. And, how are you approaching it or not? And this is for everybody. So if one of you would like to get started, if not, I'll call you. Cyndee, your mic is open. Would you like to share how you came to think about tobacco harm reduction?
Sure, I'd be happy to. Thank you for that reminder. So I'm pretty much a lifelong tobacco smoker and nicotine user at this point. I think as a young person entering the world of harm reduction and public health, smoking was a huge part of my self-care and kind of my, it wasn't part of my identity necessarily, but I have said this before. I rolled my eyes at tobacco harm reduction conversations so hard for, the majority of my career because, we had people dying in the short term of things that were much more relevant and much more serious and much more dangerous. And I was like, smoking is like the only good thing that I have going on right now. And I'm definitely not going to, there is no desire to quit. And then, I think many of us experience, I changed my mind. I, thought about quitting smoking for a really, really long time. I finally feel like I had the tools to be able to do it, in a way that felt good to me. And then I did it, right? Because I had the tools and I actually wanted I went from pre-contemplation to contemplation, and then into action. Like I actually felt like I had a like vaping gave me a path to do that. And I, after smoking for more years than I care to admit, I seriously started quitting last year. It took me about 6 months, and I've had 2 cigarettes since October, and I didn't actually finish either of those. So, I think it's been a journey, but that's kind of, I'm glad that I'm here.
Thank you for sharing that, very personal journey. Interesting to hear how you were, not with it, and then you decided, to give it a shot. And I hope that it's inspiring for, for other folks that are joining us here. So yeah, Kevin, you also have a story about, tobacco harm reduction. With yourself or with the communities that you serve. Can you talk to us a little bit about that?
Yeah, yeah. Thank you, Gabby. Yeah, so hello, Kevin Garcia here. And I first started I guess thinking about tobacco harm reduction when it applied to myself personally. Many years ago, over a decade ago, I was in a rehab inpatient or outpatient actually for substance use. And then one of the behaviors that, I engaged in was smoking weed. Very much enjoyed that. And when I was in that program, I was getting drug tested, so I couldn't really use it. And so I looked around me and everybody had like a vape. It was that time where like the vaping was really popular, like with the cartridges, like they're first getting available maybe a bit over 10 years ago. And I just started using that. And that was over 10 years ago. And here I am. I still have my vape. I'm still vaping many years later. And eventually I started to learn more about it, and after the rehab, I started getting into drug policy through Students Responsible Drug Policy, and I learned about harm reduction, and I still kind of I was vaping at the same time as all of this was happening too. And after some time, I started realizing that, this is like a form of harm reduction. And eventually I started writing for Filter Mag on the topic of tobacco harm reduction. And one of my big focuses was after working on that for a while was that trying to bridge the gap between the tobacco harm reduction and the more traditional drug-based harm reduction communities, because there's like, this big disconnect that's happening. And I feel like it's not good. We should be in cahoots. There's a lot of opposition to harm reduction, and I feel like with how little harm reductionists there are compared to like people who like love the war on drugs, we need to come together. And I'll leave it
Thank
at that for now.
you.
Yeah.
Thank you, Kevin.
Yeah.
It's interesting how both you and Cyndee mentioned, this vaping as self-care basically. So that's interesting to hear and for us to really ponder on that connection between the ways that people who use drugs and use also nicotine kind of like merge, and how we use the different coping mechanisms. And we are going to address what you said, Kevin, a little bit later on about, some challenges to that integration. But I want to hear from Annie, how you came to think about tobacco harm reduction within the communities that you serve.
Yeah, well, thank you for having me. My background is I grew up in Appalachia. Smoking was all around me. Um, I smoked. It was just very common in Kentucky. And at the same time, my dad was struggling with addiction. It started with opioids and stimulants since I was born. And he went into treatment inpatient when I was 5. And I think that really drove me towards addiction research. So I ended up seeking out a PhD, and it so happens even though I was slightly more interested in things like opioids and stimulants because of, to me, right, tobacco, it's a long duration of the health impacts, and those seemed so urgent. But I got fascinated with nicotine, actually. So I got into the field less about, reducing smoking and more nicotine in some publications that have come out about nicotine enhancing cognition. And so that's really where I started my research. And I think it helped. I was not in I got my PhD in 2007, and that lab was, I would not say a tobacco harm reduction focus lab, but I was always looking at nicotine for its potential benefits and studying that and showing that. But I really didn't get into the THR world until 2014, when it was related to e-cigarettes coming out. And I was doing, at that time, I was with Penny Associates, and there was a Surgeon General's report released by on e-cigarettes. You all might remember it's from 2016. And I read it, not to be too critical, but it was poorly done and really focused on the harms of e-cigarettes and also the harms to youth and their brains. And so I wrote a critique of it, and got it published. And that really started me on this path thinking about THR through a different lens, and that would be older adults, because at the same time, my dad passed away at 63, no doubt impacted by all his substance use, but he was still smoking. And so it became more personal. And then, so since then, I've been looking at ways to integrate tobacco harm reduction into settings where older adults are. And I'll talk to you all about it today. In my department, we have a pretty large outpatient opioid treatment clinic in West Baltimore, and was able to talk to the clinicians there and integrate a THR protocol with e-cigarettes versus usual care, and found some good things. So happy to share those perspectives when we get to them.
Of course. Thank you so much for sharing that. I love how, you're bridging that personal story with the research. It's a lot of what motivates, good research, good findings, critical thinking, is when we are rooted in, lived experience, not only yours, of course, but of the people that you want to serve and who the research is for. So really appreciating that. And really appreciating the fact that you were studying the benefits of nicotine, and not focusing on the harms. Because if we know that there are benefits, we get to understand better why people engage with that substance. So really appreciate that. And yes, I wanted to also ask, about attitudes and thoughts that you have heard from the people that you serve and work with about, reduced risk options like vapes and nicotine pouches. Cyndee turned off her mic, so I wouldn't call on her. All right, let's kick it off with Kevin. Would you like to share, attitudes and thoughts that you've heard from people that you serve and work with on these options?
Yeah, I would say I reflected on this when we were kind of reviewing. I spent the last few days thinking about it, but yeah, I serve yeah, people who use drugs, part of a harm reduction program. You're very, we all know what it looks like. And as far as the people I serve, it's it's pretty evenly split with like smoking and vaping. But the interesting part is that we don't really talk about it at all. Like we will ask about substance use practices, for instance, like what route of administration you're using the substances, and we'll have a lot of conversations regarding like reducing harm when it comes to like the more traditional drugs associated with harm reduction. And despite the high rates of tobacco and nicotine use, whether it's like vaping or the pouches or smoking, like it's never a conversation. And and it makes sense. A lot of the time, when you work in local government, you're you got to do what's funded essentially. And if there's no funding for tobacco harm reduction, then there's no conversations. And if there's no conversations, there's really no progress. And so it's hard to start something if there's not kind of like that support behind it. And I would say like we have
So
oh god. Yeah,
I was
I'll stop
gonna,
there. Are we good? Yeah, thanks.
yes, yes. I was gonna say no. Just like a follow-up. Have people that you are, providing your services to brought it up themselves that they want, to know about these reduced risk options. But I know that the infrastructure is not there to provide the support, but is there curiosity from the participants regarding options they might have? Not that it's like an institutional thing that you bring, but that they bring to you, if at all. Kevin?
I think I can,
Okay, yeah.
oh, Kevin, sorry.
Sure, Cyndee, you can hop in.
I think that I can talk about that. Like, we aren't necessarily seeing folks coming to us like organizationally. I think that part of that is because no one knows that we necessarily have, like, we haven't had the time to really engage in this conversation. What we are seeing is folks kind of noticing that, like, staff are vaping, as opposed staff who used to smoke are now vaping because they see us doing it instead. Interestingly enough, like, I'm having, I think, again, as in the beginnings of harm reduction about anything, it's been mostly peer-to-peer, right? My neighbor is a lifelong smoker. She's a DC native. She's in her 70s, and she used to, like, come and get cigarettes from me all the time. And when I stopped smoking, I was like, I don't have that, but I have this. And I gave her a vape. And she was like, oh. And then she was like, these are amazing. And, and so, like, all harm reduction methods, like, it's, for us at least, and what I'm seeing is it's more peer-to-peer. Like lots of people at HIPS who used to smoke cigarettes all the time started switching to vaping because I had switched to vaping, and they were asking questions about it, and we were talking to each other. I mean, that's how harm reduction works, right? It comes from people in the community sharing knowledge with other people in the community. And that's how I see kind of things organically with the movement happening right now. I think that if we were able to have tools and materials to be like, hey, do you want to try this out? And here's why this may be better for you. You know, we've talked about, like, the problems with going into a healthcare appointment smelling like smoke, not wanting to go into a shelter overnight because you can't smoke there. Like, you can't vape there either, but, you know, like, there are reasons that people, you know, get stigmatized because they're smokers. And vaping, like, it, you know, helps reduce a lot, like, some of those at the very least.
Of course. And thank you so much for bringing up the fact that people don't have the best experiences with healthcare and housing services because they are not allowed to smoke, or even because they feel like they're being stigmatized because they smell like smoke. So that's like a direct impact of not having that infrastructure that Kevin had mentioned that can support tobacco harm reduction. So Annie, can you tell us a little bit about those thoughts, attitudes that you've heard from the people that you work with?
Yeah, I'd say my work with the community, and I'm doing a lot of outreach with senior housing in Baltimore and beyond. Way curious, very open to the idea of harm reduction, really pragmatic. My biggest barriers, I'm in a medical school, honestly, are clinicians, often MDs, and public health officials that, honestly, when I talk to them, because I give a lot of presentations on trying to educate on tobacco harm reduction, there's just a lot of pushback, a lot of lack of knowledge, not just about products like vapor products, but nicotine in and of itself, thinking that nicotine is a direct cause of cancer. And they often bring up EVALI, popcorn lung, and they won't even hear it. Some of them, I would say it's probably like 30% of the room. They're just convinced, one, that things like e-cigarettes and pouches are just ultimately horrible for people. So I think that's been my biggest challenge, which is very interesting because it goes to show, I think, that communication around this and corrective communication, it not only needs to come from the top down, like in terms of medical school training, but often I'm finding it best, right, in community setting, talking to people, and it's smaller steps I'm taking. I'm hopeful that some of these clinicians are seeing that I'm sharing evidence. I'm not just up there talking about my personal experience and opinions. And but that's what I see as one of our biggest hurdles, and some of these public health representatives might be, at community level, city level, and then it makes it a challenge to get programs funded that might, for
Mhm.
example, focus on that tobacco harm reduction.
Thank you, Annie. And, to that point, shameless plug, National Harm Reduction Coalition at harmreduction.org. We have some resources, educational resources for the general public, and that are really great for also professionals. We have a myth-busting fact sheet. We have the principles of tobacco harm reduction, which are a really good way, kind of easy to read resource. And Kevin, I know that you wanted to kind of round up that curiosity conversation that we got started from your participants.
Yes, I got lots of points, but yeah, I wanted to follow up with something like Cyndee said in one of the planning meetings that I've heard a lot from other harm reductionists as well, and I also agree with, but that sense of urgency surrounding like harm reduction with certain substances, like with nicotine, the harm could come in many, many years, whereas like with the tainted drug supply, I mean, the harm could come very quickly. And to follow up too with Annie was saying, I definitely have found the same as far as it's very difficult for some reason for people to want to adopt tobacco harm reduction, even within the harm reduction circles. Like lots of misconceptions. The amount of times I've heard that vapes are worse than smoking in all sorts of circles is like shocking. Like now and nowadays, yeah, from family,
Yeah.
friends, like professionals, like all sorts of fields. Like I also hear about the Valley bit a bunch, and and sometimes it gets to the point where there's so much misconception that it's like it almost drowns out like the reality of it, and it makes it difficult to advocate for like THR without that more like institutional backing of like that harm reduction has. For instance, like there's so many orgs practicing harm reduction, you could point to like dozens and dozens, but it's a lot harder with the THR. So thanks. Yeah.
Thank you. That is on point about the conversation of this integration. Aside from the institutional backing, the misconceptions, like I've heard it from my niece. She's 23 years old. She picked up smoking because her friends told her that vaping was worse. And it was just, wow, where did they hear that from? Well, the news, just it's kind of like common knowledge, quote unquote, that it's worse when it actually isn't, because of the combustion piece is really not there. So I will take a short break to drink some water, and Jessica, you could continue with the combo.
Yeah, I mean, just piling onto that, one of my pet peeves is, in this line of work, I'll go to public health conferences. And there's wonderful support. Like to your point, Kevin, without the institutions that people trust, and we live in a time with pretty low trust in institutions, but there are still some that people listen to, that journalists listen to, the public, lawmakers, et cetera. Without the acknowledgement and even just not repeating the debunked myths would be helpful. So I'll, go to these public health oriented conferences, and there will be many, like a whole track on harm reduction and drug use, harm reduction and chemsex, harm reduction and syringe services programs, drug checking, naloxone, medications for opioid use disorder, all super important, and lots of conversations around people's dignity and autonomy and meeting them where they are, that people use substances for reasons, and we need to understand that and not just tell them that they need to be abstinent. And, that there's, without removing all risk, there's ways to, reduce risk. And then there'll be like one session on tobacco, and it's about tobacco control and banning not just combustible tobacco, but all nicotine products forever. After all these sessions that talk about how, the drug war and criminalizing and banning substances has harmed a lot of people. So it's a fascinating conundrum to me that I do agree it's a real barrier to folks even being open to having the conversation without those big trusted institutions kind of coming along with the evidence base. So anyway, just underscoring what you all are saying. So this is all a little doom and gloom, but let's talk about successes, personal, organizational, institutional, or any of you having, and Cyndee, you touched on this a little bit, seeing successes in having conversations with folks, whether they say to you, like your neighbor or there are others. Kevin, have you had peer to peer? And I think it's such a great point that there's such a mirror to, the early days and ongoing to this day peer to peer nature of harm reduction and drug use. So are you seeing successes? And if you aren't, or even if you are, what would success look like for you in an ideal world for the organization you work for example, for Cyndee and Kevin, to take on tobacco harm reduction in a more concerted way to be able to offer folks. So talk to me about any successes first, please. I'm hoping there's a couple. No,
Yeah, I'd
silence.
say
Kevin,
it's
let's.
yeah. Oh no, go ahead if you want.
No, please, please.
Real quick, but there's a nicotine replacement program in at the health department that I work at, and so they do offer some nicotine products for folks, and it's free, it's low cost, and they have some options. They got like patches and gums, lozenges, and it's just missing a few options like the vaping, for instance, is not there. And personally, as the harm reductionist, it's like sometimes people are dependent on like the ritual. That's a big part of it, and
Mm-hmm.
it's not really talked about, and I'd love to see a little bit more of that. But there is some nice things. Like, it's nice that it exists, and there are options, which is it's certainly better than nothing, and certainly better than just saying like don't smoke.
Right. And it is interesting, right? There is so much, as all of you have been saying, misconceptions among healthcare providers that nicotine is a driver of cancer, yet we have these approved products that deliver nicotine to folks as a way to help them manage cravings. So some disconnect is happening here. Annie, we would love to hear. I think you've got a success story to share with us. So
Yeah.
I think Annie's going to show us some things and talk about your work at this OTP, colloquially what many people would call methadone clinic in West Baltimore.
Yes, and I won't be too nerding out on this. I know there's sometimes too many data points and all that can bore people, but I did want to show you all just a quick overview of what I did. We just finished the study, and so I'll start here with the clinic I work with. So, okay. So basically, we're in West Baltimore, if you're familiar. It's near my campus, but a little further out on a primary bus line. So we have a pretty large census, about 400 people to 500 at any time. We do have buprenorphine, but most patients are on methadone, and often that's their choice. And I'd say most often. And most of our patients, you can see here, are older. So we have an aging clinic, which you see across the US. Older adults are the fastest growing demographic in terms of age in OUD treatment. And then we also know in Maryland, and this is nationwide, fatal opioid overdoses significantly impact people 55 and above. And that's been for several years. And it remains the same even with some of the recent drops. So I went to this clinic and I work with them, and the medical director was very interested in this topic, very open to it. It's a very, as you might imagine, harm reduction focused clinic in all other capacities. In terms of needle exchange, naloxone, they've got wraparound primary care services for wound care. So I enrolled, I got a small grant from Maryland to do this, patients 50 and older. 50 is quite a young age to define older, but we do that for a couple reasons. One, to just make sure we recruit enough people, although I think we would have had plenty over the age of 60, which is sort of the international definition of aging. But also because, as you might imagine, smoking accelerates biological aging. There's several studies on this. So someone that say maybe 50 years of age and has smoked for decades, which is most often the case, would be an advanced age from that. So maybe 55 on average. So our participants, you just see here, they were mean age 60 out of 29. We had fewer females. Our patients are pretty much not employed. We have a lot of housing instability in our population, so we're really reaching low income patients. And I just wanted to highlight attrition. Our usual care group had a much higher number of people dropping out of the study. And I'll tell you what usual care is. It's what we do at our clinic, which you may see at other clinics. So anytime people come in for an intake, which is walk up, they can come anytime. They're going to complete intake procedures with the counselor. The counselor is going to ask if they smoke. And then they're going to ask, do they want to quit? And then if they say yes, they're referred to a 1-800-QUIT line. We do not have NRT, any other medications like that easily accessible. They can be prescribed. So the usual care we implemented was the same, probably a little bit more because we asked, do you want to quit? Nobody that participated in this study was interested in quitting. They had low motivation to quit. And we just basically did this usual care 4 times when we saw them across 8 weeks. And a lot of people dropped out. They told us they actually came into the study because they wanted the e-cigarette. And then you'll see here, they had smoked for an average of 40 years. Most were smoking menthols. Sorry, that comes into account when we look at flavors. Most were on methadone, and many people had, not previously tried to quit. So what we found is after I gave them either e-cigarettes or the usual care, they had no instructions to quit smoking. We gave them an Enjoy ACE, which is a rechargeable device that's FDA authorized. Happy to talk about what that means with everybody. And then all we did was just give them that. I did give them tobacco harm reduction education at baseline, which I'm happy to discuss how we frame that. It also gave education on things like nicotine is not the direct cause of cancer. So what you see here is that significant reduction in the purplish line in the e-cig group compared to the usual care. So you still get some reduction, and this is across, like I said, 8 weeks, but much more, significantly more in the e-cig group. And we also found that 6 people reported smoking no cigarettes at the final follow-up in the e-cigarette group versus 0 here. So you see, like, not only were they reducing, a lot of people quit. And again, this was without instructions to quit. We got really high acceptability of the e-cigarettes. Most people chose menthol. So I think flavor is an important element. And we are in the process of publishing these findings. And then one other thing, this is just of interest if you're looking at this. So the way we measure abstinence and confirm it, in addition to self-report, is something called expire air CO. It's just a little box. You breathe into it if you're not familiar. And so CO is highly correlated with smoking. But of course, e-cigarettes do not burn, so they don't deliver it. So this would be our gold standard of, abstinence here. And we do see a difference. So we see reductions in CO. I have a hunch because our population, so these were individuals, they had been in methadone treatment or bupe for about 3 months, but we looked at their charts. We're really liberal, I would say. People can use substances while they're on the methadone. They can use fentanyl. So about 50% are positive for fentanyl, but often they're smoking fentanyl, cannabis, or cocaine. So we think that some of these expired air CO readings, which actually can be influenced by any drug or anything that you smoke, were influenced. But what this tells us is the reduction in cigarettes was translating to reductions in CO. So that's my brief little nerding out, but I'll sum it up to say this feels like a success because these are individuals that most had never heard of an e-cigarette. E-cigarettes aren't common, or weren't at least a year ago in our clinic, especially among adults 50 and above. We did measure misperceptions at baseline. In fact, 40% of our patients thought that nicotine replacement therapy was equal or more harmful than smoking, and slightly lower for e-cigarettes. They're actually more informed on e-cigarettes. And nearly all thought it was direct cause of cancer, COPD, and cardiovascular disease. So there's a lot of room for improvement, but I feel that the participants in our study really got benefit of these e-cigarettes, and they were, in their exit interview, quite excited about the prospect of sharing this with other people. So we have some other projects planned, and hopefully can get funding for programs to not just make this a research study, but actually access to these products.
Super cool. Thank you so much for sharing this. I knew you were engaging in this and waiting for it to hear how it went. How do these folks, I mean, you said you've got some housing instability, quite low incomes. Did you get a chance to talk to these folks about their plans for continuing to get access to these products, and how do they compare in the area where they live from a cost perspective to getting cigarettes?
Yeah, I mean, in our area, honestly, e-cigarettes are quite expensive. I'm not sure there's a big differential with smoking. It's a problem. They very income limited, and in fact, a lot of times in our study, they would say they hadn't smoked the week before only because they couldn't afford it. And so they really enjoyed having the e-cigarette to offset those costs. So if there were a way, to supplement the cost, reduce taxes. I think that would be an excellent incentive. And we asked them at the end, I'm still looking at these data. We haven't published them or put them in yet for publication, but we asked them, do you plan to use this e-cigarette to continue quit smoking or just to use it? And they said yes, nearly all of them. One person tried the e-cigarette at the start, did not like it, and didn't want to use a replacement, which I think it very much matches, what you'll see in the real world population. So I think there's promise. I think the biggest challenge was cost. They
Yeah.
can buy them right next to their cigarettes, but I'm not sure if they prefer the cigarette because it's what they've had. It's hard to compete with that.
Yeah, and my colleague Jeff Smith here at R Street has written quite a bit on the impacts of, we've seen places, municipalities that ban the sale of vapes but allow cigarettes to be sold, the deadly option, or, increase taxes on vapes and nicotine pouches. Again, making them as expensive or sometimes in some cases more expensive than combustible cigarettes, which drive the, close to 500,000 smoking related deaths in the US every year. Kevin, tell us about Referendum 310.
Yeah. So my English is not my first language, words, but the word you said 310. So
310,
basically
yeah.
banned flavored tobacco products in Denver, the sale of. I remember walking into a store because I make my own e-liquid. It's a lot more affordable and accessible. It's like way cheaper. So it'd be nice if more people did that eventually, but that's a whole nother segue. But I try to buy a e-liquid, and yeah, you currently cannot buy one within city and county limits. And so I could just go like to the next city over, which like Denver Metro, the cities are all pretty close to each other, so it's just like a drive over, but it's ridiculous. I remember when they were first trying to pass this, and there was a lot of business owners who said like, hey, we make like 50% of our profit from these products. If you make this reality, we're gonna have to close shop. And it did pass, and a lot of places did close shop, and it's a lot. It's pretty harmful. I mean, and it really just helps the people who coincidentally, have a business outside of that area, and just it really supports people not adopting THR in our communities because the assumption is, if the city banned it and like cannabis is legal, oh, one must be bad, one must be good, and that causes those misconceptions. And there's a lot of work to do. There's progress, but a lot of work to do still. Yeah.
Speaking of access, Annie, would you talk a little bit about those Enjoy products?
Yeah, so an interesting thing during our study, I bulk bought these products through a manufacturer, no, sorry, through a distributor, which really helped me save money, but they got pulled from the market. And that was really hard to explain to participants. The reason was a patent infringement lawsuit filed by Juul against the maker of the Enjoy Ace, which is, I believe, Reynolds. So they were pulled because of this legal dispute, not because they lost authorization, which suggests that, like, in the grand scheme of public health, the FDA authorized these products after reviewing their applications and determined that they could improve, I'm messing this up, but improve public health because they could replace cigarettes. So we had to explain that to participants, which is quite confusing. They were concerned because they really wanted to keep vaping, but they could no longer buy these products. So we referred them to other products. My main concern was making sure they're getting the cues and the nicotine. And we didn't have any money to do a follow-up analysis on that. So I'm hoping they could switch. But yeah, actually the Enjoy Ace, I'm thinking about it. Actually, I don't know who manufactures that, but anyway, it's a problem. It's still not on the market if you're interested in that vape product.
Got it. Okay. Well, so we were talking about successes, but quite a bit of discussion of barriers going on here too. So we're gonna take a second and pop into the Q&A and hear from Mazen, our Mazen at R Street, who says historically there has been friction between health professionals and harm reductionists. Is this still the case? If not, are there learnings from cultivating those relationships that can help set the record straight on tobacco harm reduction? Open forum. And I think, correct me if I'm wrong here, Mazen, or if you all read this differently, he's referring to, like, historically on harm reduction in drug use, there have been some frictions with health practitioners, and maybe that's gotten better over time, but what parallels do we see here? I think that's right.
Well, I can speak a little to this as I try to merge our harm reduction focus in other substances, right? With how I talk about tobacco. I found that to be pretty helpful. I find that starting with, especially in Baltimore where we've had issues with cocaine and opioids for decades, people will hear the needle exchange topic, naloxone. So I've had some been able to get into those conversations. I think I just speak for myself, and this is also why I focus on older populations. There's just, and I don't know if you all feel this is in other areas of substance use, a hyper focus on youth and youth protection that even when I'm trying to draw those parallels, it ends up sort of like spiraling away from the conversation of like harm reduction broadly, and just like you cannot have harm reduction when it impacts youth like this. And of course that's a complex topic because tobacco smoking is harmful, but what is nicotine without smoke? How harmful is that? And what if youth are initiating e-cigarette use and not smoking? But of course those aren't topics I want to get into. I want to get into harm reduction for people who currently smoke or potentially could. I don't feel super amount of hope. Well, I will say that I've been working with a professional society, and we just got an article accepted for publication. I'll share it as soon as I can, Jessica, that's giving guidance to US based clinicians on e cigarettes as cessation tools, and that'll be in JAMA. And so I think that that could be a great thing for you to
Is
share.
Patricia Theo part of this paper, or is it
Yes.
separate? Okay, great. So we did an event last week. I linked it in the chat
Oh,
on HIV
great.
and smoking, and she teased that as well. And now we're all waiting with bated breath for that to come out because it sounds great.
Yeah, we officially got it accepted yesterday, and I think it could be a really good document for sharing around to have these conversations.
Yeah, we'll get that out to the list for sure. It's interesting. I mean, it's taken a little minute, but the federal government does this annual study of, the National Youth Tobacco Survey. And just this morning, we had a journal article come out, Nicotine and Tobacco Research, breaking down that data. It's taken a little while, I think, to get some of the analysis here, but everything's down in youth use. This is great. This is great news. Um, the kind of analysis of the article says that the survey shows this is a quote, significant decline in the prevalence of any tobacco, any combusted tobacco, and e-cigarette use between 2022 and 2025. So, I mean, I don't know why we don't celebrate this more because it's very exciting. I got two teenagers. Like, I'm thrilled to hear this. It's great. It is great news. And suggests to me that we can walk and chew gum, that we could do both things at once. And this is, youth use is down while you can buy all kinds of vapes and nicotine pouches, many of them not approved by the FDA, all over the place. So prevention's working. I think, raising the age to 21 is working. Education's working. These things sometimes are cyclical in terms of what's, cool and desired by youth. But I agree with you. We hear a lot of the kind of, what about the kids thing? And it feels like these numbers suggest to us that we can do both, but I don't know what the answer is to get past that. I don't know if the rest of you have any thoughts or if you've come across that barrier. If not, let's go back to Mazen's question around friction and healthcare providers. I don't know if we could hear from Kevin first and then maybe Cyndee, what you think about this.
All right, let's do it. Okay. For me,
Do it.
because it depends where you are. So perceptions of harm reduction differ. Like for context, I had to move to Colorado from Florida to kind of like pursue a career in harm reduction, and it's still not very widespread in Florida. And so of course, there's less acceptance of harm reduction in Florida, but like think about somewhere like Colorado, and there is a wide acceptance of harm reduction amongst you know, like government officials, local government, state government, and of course, like depends county to county. Like I remember I did a job interview for it was like one of the more rural counties, and they did not like harm reduction whatsoever. And so it depends like where you're at. but on the wider lens, I also attended a conference, the National Association of County and City Health Officials, NACHO, and I had people from around the country that worked in, county and city government. And there was a good amount of harm reduction conversations, and it seems like people were accepting it. And so I would say that overall there is a growing acceptance of harm reduction amongst public health professionals. But one caveat is that it does feel like harm reduction is getting diluted in 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 some ways, like philosophically. And I'm talking about like I guess like the big HR versus little HR, as far as like harm reduction is a social justice movement for and by people who use drugs, and it's not simply a way to reduce harms. And so there's pros and cons with like the wider uptake of harm reduction. And I feel as it grows and as THR gets integrated, we have to kind of remember the roots of harm reduction and how it started. And it's really important.
And that can be hard too, right? Because the products specifically related to tobacco harm reduction are produced by big companies, right? These are not like sort of peer to peer. Like if you think about the history of drugs and harm reduction, kind of, homemade bleaching, cleaning your works, like this was not a corporate thing at the beginning. Of course it is. Right now we have companies that make naloxone, that make test strips, that make. We live in a society, and that's what happened, right? So, but I think that I think of that as a barrier too in these healthcare spaces and public health spaces, is like, how can this possibly be actual harm reduction if big companies are making money off of it? It doesn't feel right to a lot of people. To which I say, like, I sort of cutting off your nose to spite your face. If it works, if, in Annie's study, it helps people switch, even if they've said they don't want to, and it helps them improve their health, then it is what it is. But that seems like a pretty hard hurdle for a lot of folks and institutions to get over. And I wonder if you all have seen and heard that kind of resistance as well.
Yeah, I think, I mean, we look to DC, for example, right? Like, it's not necessarily an easy time to be doing harm reduction-based public health in the world out there right now, and especially when you're interacting with government and federal agencies, right? I think that there's a lot of pushback on the words harm reduction, but there's, an understanding that the tools and the access and the services that harm reduction provides does work, right? We can look to DC for an example. For decades, DC was not allowed to, do syringe exchange. We weren't allowed to locally fund syringe exchange because of our situation. And we finally were allowed to, and new HIV infections went down 90% in just a couple of years, right? Because we were able to implement the tools that we knew would work. And I feel like, we have the same opportunity with vaping. I think public health knows that we want people to not, free-base tobacco. People, we know that there are tools that can help people not do that. We have the education, we know the science. And while there may be an understanding of all of that and the capacity to educate around all of that, whether or not we have the political will to actually get to where we want to be, I don't know. And I think that's a dance that we do with our public health officials, but it's that harm reduction works, and that's how we've reduced overdoses in DC, which had one of the highest overdose rates in the country, is because we were able to expand naloxone access. And so this is just yet another, I think, tool and a way that is gaining a lot of traction and gaining a lot of success. Just like other public health approaches have over the years, other than just saying well, just quit smoking. Quitting smoking. I was a pack-a-day smoker for 20 plus years. Quitting smoking was not something I was going to do, ever, probably. And then, there was new tools that worked better, and that's how change happens.
Before we jump, we've got another thank you for that, Cyndee. I mean, super powerful. And yeah, I think you're right about the peer-to-peer thing. I'm a very impatient person, but clearly that's the conversations that need to happen. Your story to the next person, to the next person. Before we jump, I know we have at least one more question in the Q&A, but let's do a couple shameless plugs if that's all right. I will put in the chat R Street and PPI, Progressive Policy Institute, are co-hosting on June 30th. For those in DC, or if you have colleagues or friends interested in this space in DC, we're hosting a happy hour on Capitol Hill, a Sonoma wine bar just off Capitol Hill, or just off the, just on the hill, off campus, for kind of celebrating the Congressional Tobacco Harm Reduction Caucus, which has grown quite a bit and has become kind of more solidly bipartisan, which is great to see. It'll be very informal. It's not a heavy program at all. Good vibes only, just, getting together with people that care about this issue and want to get to know each other. So I'm going to share that link in the chat now, and then over to Gaby, who I think has a shameless plug as well.
Yes, I do. Thank you, Jessica. So today, right after this, at 4 Eastern, NHRC is hosting a tobacco harm reduction office hours. Today, I just dropped the link to the Zoom meeting in the chat. Today, we're going to be addressing motivational interviewing for tobacco harm reduction. And, this is a great space to bring all of your questions, your experiences, and if you have suggestions for THR integration, they are very much welcome. So I just dropped the link in the chat over there. And these are hosted monthly. So let me share. There's a sign up sheet for this. I wish I'm sharing right now. And now we are going to be moving on to the last question that we have on Stack, which came from, let me look for it really quick. Sorry, I'm doing like 3 things at once. The sign-up sheet, I just put it in the chat. If you want to go to other office hours, they're going to be running until November. And now to the Q&A. So Cheryl Olson is asking, can you share examples of stories or information that opened a skeptical mind from no way to maybe for tobacco harm reduction in a one-to-one conversation? I will share a story of mine and then we'll pass it on to the panelists. So when I worked in outreach, in Puerto Rico, in the east side of the island, part of the way that I connected with the people that I was serving was by giving them a cigarette. And, that kind of kinship, if you will, was really strong. It built trust. And when I switched to vaping, right now I'm a dual user, so I still smoke and vape, but I smoke way less. They saw me make that switch, and they would still ask me for that cigarette, but I would take that opportunity to start talking about the benefits that I had felt in my own body from vaping. So I remember this one time I was telling this participant at the methadone clinic, like, oh my gosh, I can now run a mile without being like super winded. And he was like, wow, I can't. Wow, really? Are you sure? And I'm like, of course I'm sure. It's me running. It's not somebody telling me, that they're breathing better. And he was open to trying it. So that was, one small little story. It just took me like a minute to tell him that. And he was open to the idea of trying a different thing. I wasn't versed in tobacco harm reduction, so the only option I knew was vaping. But had I had more information, I would have also talked about maybe, vaping is not for you, but you might want to try a pouch. But just the fact that that conversation came from a fellow person who smokes was really important because we had already, built that trust. So hopefully I answered. And if Annie, Cyndee, or Kevin have any more, examples of that, that would be great to hear.
Well, I can just add, I think that for me, I'm really focused on data and bringing it. So I think these conversations and that to me is frontline. We have to be doing it. What can I do with my skill set? So what I've been trying to do is remind people that more people smoke tobacco in the US than they vape or use these other products. it's a forgotten population, and I hate to preach too much, but the focus on youth, it's the headlines turn to e-cigarettes and now they turn to pouches, but we still have a large amount of people still smoking. I think it's hard to argue with that, and I've been trying to bring in the health equity lens, because if that's really what we're doing, if that's what public health is doing, then we're really missing a large group of people. For example, smoking prevalence among older adults who live below the federal poverty line increased in recent years. It's the only increase we've seen. And those are, very marginalized people. I don't know how effective it is, and I'm not sure if that's helpful, Cheryl, to your question, but it's what I'm trying to do, and really try to see people for the blind spots that they're for a variety of reasons, but I think mainly because of this focus on youth and also novel products. We're forgetting that, combustible cigarettes are still here and not going away fast.
I think there's an element of writing people off, which it just really bothers me on a deep level. Like, a lot of us grew up, I think, with a lot of smoking around us. I certainly, had smoking in my house, in my car, everything. And it was just sort of fatalistic. Everyone's grandparents smoke, everyone's this. And so I don't like the idea that we've just given up and we just write off, especially, the most vulnerable pockets of the population, whether it be people with, overlapping isolation, mental health, older folks, veterans, people with HIV, like the event we did last week, people who use drugs that smoke at very, very high rates, that it's like, well, there's nothing to do about that. So, there's no point in trying to bring anything to the forefront that might help those folks, because we've just sort of shrugged our shoulders already. So, yeah, I hear you, Annie, and I hope you keep fighting the good fight. I know it's uphill, but I value it. I appreciate it.
I think Cyndee wanted to share a one-on-one story, if I'm not mistaken. I saw you open your mic. I don't know if that's what you were going to talk about, Cyndee. So we have like 2 more minutes.
Cool. Really quickly, like, some of the conversations I had with my neighbor when we were talking about it is, she was winter's a great time to start vaping, because vaping doesn't take as long as a cigarette. And so if you have to vape outside, you don't have to vape as long outside as smoking a cigarette. You get to choose the amount of nicotine that you need at that time, as opposed to just always finishing a cigarette or 2 cigarettes. It doesn't, you can vape out a window and people don't necessarily know that you're vaping. Like, the smell, I was personally done with the trash and the smell. And, that's what made me want to stop. But also for her, it was that it lessened the amount of time that she needed to use, and she didn't always have to go outside, which were other 2 things that were just really great about vaping and over smoking a cigarette.
Also, Cyndee, just wanted to cycle back, because I did think it was so powerful, so much so that I brought it up in our event last week about HIV and smoking. As you mentioned earlier in this conversation today about, I think it was you, about stigma that people face in healthcare settings when their clothes and hair, their person smells like cigarettes. If the 5 of us had our way, we would wipe all stigma away from the world, but we live in the world we live in. And if it's a tool that both helps people reduce their risk, switching from smoking to something that is much lower risk, and helps reduce the stigma that they face when going to healthcare settings for all their other needs. Like, that had not occurred to me. And what a, kind of wonderful byproduct if it means that people can walk in with a little bit more confidence and be treated a little better in the healthcare setting, which hopefully would help them keep coming back to healthcare, which is an issue for people that face stigma. So I just wanted to underscore that, because you mentioned it, and it really hit me. So I wanted to say it again. Well, I think we're at time, folks.
I've experienced that.
Yeah, go ahead, please. Folks can drop off if they want, but we've got a lot of people hanging in with us.
I'm a pretty savvy healthcare user, and I've experienced that personally. So I definitely know that it is something that my neighbors and my friends who smoke definitely talk about, right? And it's a real challenge, even as we said before, to the point where medical providers aren't necessarily educated about what's going on with this. And so I've had doctors tell me that vaping is worse than smoking. And if I'm getting that information, what misinformation are we sharing with everybody? And hopefully that can change because of tobacco harm reduction.
Well, thank you all so much. We are right at time, but super grateful to all of you. Gaby, your co-hosting skills are unparalleled. Thank you so much to NHRC for doing this with us. And to Kevin and Cyndee and Annie, thank you for what you're doing in every sphere of what you're doing, and for sharing your stories and helping put this issue in a more pragmatic and compassionate light, which I think is really needed in this space and is like kind of weirdly missing from a lot of conversations around tobacco harm reduction. So thank you for everything you do in this space and others and in all the places that they overlap. We really appreciate you all. And thank you to our dozens of attendees that stuck with us past the hour. Really appreciate it. We will send a follow-up with video, links, all kinds of resources. And always thank you to our events team at R Street who pull these things off. So thanks y'all very much. Any other closing words? We'd still have 20-something people with us running over the hour if y'all have anything else you want to say.
I wanted to thank our panelists, and Jessica, I wanted to thank you. It's been a pleasure having this conversation. Let's do more of this. So let's keep it going, and we will see you at other events. This is a series, so watch out for the invites. Thank you.
Thank you all so much.